Mike, thanks so much for joining us. What's your first recollection of seeing an echocardiogram or seeing the test?
My first recollection was the Palo Alto VA Medical Center, 1978, looking at M-mode echocardiograms. We were doing physical diagnosis. After we saw the patients, I remember a patient with heart failure, and then we went to the echo lab, which was essentially a closet.
I know. I was in that closet a lot.
You may have been
I was
there.
I was the original inhabitant of the closet.
And I remember these very, very long rolls that you had to put out in the sunlight to develop.
Absolutely.
I had no idea what we were looking at, but the teacher was obviously, enthralled with what he was looking at, and so it was M-mode echocardiography.
Isn't that amazing? Amazing. When did you get involved in the 2D thing? What happened then?
So, then I became a resident back in Boston, Brigham and Women's Hospital, moved back across from coast to coast, and I was fortunate to have cardiology attendings as a house officer who were interested in echo exposure to Josh Wynn at the Brigham,
right,
who was the director of the echo lab there, was 2D imaging.
Mm-hmm.
I spent a lot of time at the VA Medical Center, and Al Parisi was chief of cardiology there, so got to know the technicians there, and we utilized 2D echo there. So I then went back for fellowship at Stanford, and that's really where the exposure began. I was extremely fortunate not only to have the mentorship of Rich Popp and the lab, but Liv Hatley was on sabbatical at Stanford during my first year as a cardiology fellow, and so that was one of the sparks to become engaged, not just in 2D imaging, but to learn Doppler at a time when no one in the United States really was applying Doppler.
So you were in you got a chance to, the funny thing is Liv sent me the first analog Doppler machine, and she was certainly a giant in the field, but Rich and the Stanford lab certainly moved things along immensely. How'd you end up in Boston? What happened?
Love conquers all. So my wife came with me. We were training in Boston and got married after my senior year, and I moved her back to Palo Alto so I could do my cardiology training.
Right.
And the deal was that the next step would be her choice, and so she got a fellowship at Mass General Hospital in Boston, so we trucked back across the country, and at that point I knew I was interested in echocardiography. Right. So it was pretty much a natural fit to do an advanced echo fellowship at MGH, and I've been there ever since.
Was Ned there then?
Ned was the director of the lab. He'd been well ensconced at that point. That was 1987.
Okay.
So it was a very mature program at that point.
As you look at where echo was then in the late 80s and things, what were you using? What were you doing? Were you doing equipment that was state of the art then, 2D Doppler, color Doppler?
Well, I was very fortunate to be at the MGH. We clearly had state of the art equipment, which meant we were doing 2D imaging on pretty good machines, and then there was one machine that did color Doppler. The rest of the time we'd use pulse wave Doppler to sort of sample through the left atrium to try to map the mitral regurgitation.
But, a great technique.
And then, for the special patients, after the exam was done, we'd move them over to the other room and do a color exam. But very, very quickly, in the late 80s, we really advanced to have a lot more color Doppler. And just as I was leaving Stanford, we had the first TE probe.
Right.
And I remember Chris Appleton and I doing TEs on these first patients with English Nitker. So that when I came to MGH, they were just getting the TE probes, and John O'Shea, one of my co-fellows, really started to apply TE. So we were just starting to do TE mostly on patients under general anesthesia at the time.
Your recollection of TE is an interesting thing because we haven't talked about that, but it opened up another world to us, didn't it? I mean, really moved the operative room, OR, ICU, CCUs, areas where we had been but couldn't get great images. I mean,
I think the two things, at least at our institution, was striking was the intensive care units, as you said, and endocarditis. Where we had a technique that had a pretty good sensitivity, and when we say pretty good, we were probably talking 60, 70%, and all of a sudden we saw all the vegetations. And I think we became a pest to the clinical cardiologists because we were telling them about things that they weren't sure they really wanted to hear about because now we had a microscope on the heart.
How did you get active in the American Society of Echo?
I was invited to speak at the first meeting. My research was on left ventricular remodeling.
The first national meeting.
First national meeting.
Okay.
So my work on post-MI LV remodeling was just getting published at the time. I was just finishing up fellowship, and so I got an invitation to speak at the Washington D.C. first meeting, and it was a great meeting. I'd been to the AHA, been to the ACC, presenting abstracts, but unlike those meetings, it was all contained in one hotel. Everyone you just saw in the hallway, you saw them in the rooms. Very collegial people. The leaders would come up to you and speak to you. You didn't have to bow in respect. I mean, it was just a very fun group of people, friendly group of people, all interested in advancing the field of echocardiography and disseminating it. And it was just a great educational experience. And so from there, again, I continued to present the research, and I'm not exactly sure how I got involved in the leadership aspects. I did serve on some committees.
On committees.
And then moved up the field. I mean, I remember, one of the other things that I always remember is going to the AHA or the ACC meeting, on a Sunday afternoon. You'd see people walking around with these white notebooks that had ASE on them, the people who were going to board meetings or coming from board meetings. And I never really knew what that was, but you sort of said, gee, that would be something fun to do.
So you followed BJOY, and you were the, as I think, the 17th president and stuff. What do you think? What do you remember of accomplishments, challenges that went on as it impacts either the practice of echo or the society in general?
Well, I think my presidency started at about the time when a major focus was shifting nationally about healthcare resources.
Right.
And during BJOY's term, he asked me to attend a meeting in Washington, D.C., where there were a lot of the insurers. And it was one comment I remember where, I won't say which insurance company, but a rep from one of the insurance companies got up and said, we got a real problem here. We're spending way too much on cardiovascular imaging. We don't know whether it makes a difference or not. And we're going to police this if the cardiology community doesn't take care of it. And to me, that was, in a way, a great piece to take home and to sort of build into my presidency. And so we really made my year sort of the first year of quality. We really put a focus on making sure that every echo we did made a difference. And the appropriateness criteria were published during we developed and with working with the ACC, sort of worked on those and got those published. We developed a few committees to really focus not just on guidelines, but really focusing on the appropriate use of echo. Because for years we were saying, echo was great for this and echo was great for that, which we know it is, but you don't have to do it every 3 months on those patients. So we really started to have a focus on putting in the right clinical context how to use echocardiography.
You've been head of one of the premier labs in the country, and you have tremendous colleagues in not only as faculty members, but physicians, but as sonographers. The role of sonographers in this organization, the field. What's your take on that?
Well, it's I think we're a unique organization because of the teamwork and that we have sonographers playing leadership roles. I think that I must say I really respect what the sonographers do in our organization, because although I have a full-time job, I have a lot of flexibility in my schedule.
Right.
But they work a day. As a director of lab, I'm paying them to do their 8 hours of work, and I expect them to do their 8 hours of work, and yet to see that within that they're able to carve out enough time or figure out on their off hours to dedicate the time to this is always, I think, admirable. And I worry that in the future it's going to be harder and harder as hospitals and practices rein in how they're paying for this work, that sonographers will be willing to spend the time to do this. And I think that's going to be a challenge for our leadership. But I must say, during my tenure, I was fortunate to have some wonderful sonographers stay involved. I think a lot of what we do, even in advocacy and understanding the reimbursement patterns, the sonographers and the business managers of the practice know as much or more than the physicians. So it's really been critical to keep them involved.
You know, you'd mentioned the advocacy, and you obviously, with the appropriateness and all that thing, you've had a vital role. But think about it as a practice or a technology. Where do you see us going in the next 10 years, and what's echo going to look like?
Well, you know, the first comment I would make is that many of my young trainees are very nervous about just training in echocardiography alone, because they obviously everyone who comes in wants to do multimodality imaging. Right. And we encourage them to do that, but I also say at the end of the day, you're going to have to make a living, and you're going to be able to do that with echocardiography. It's part of your practice. If you're a clinical cardiologist, it's going to be part of your practice. And I think that 10 years from now, it's still going to be a big part of our practice. And the way it looks may change, or it will change. Mm-hmm. The way we do it is going to change. The devices are going to be clearly smaller, so that the point of care aspects of echo will accelerate. With that comes the challenge that we need to make sure that the right people are doing it at the right time, on the right patients. I think we're going to have to do, ASE is going to have to do a lot more training of the non-cardiologists who will be applying these smaller devices. Mm-hmm. But we still are going to need the experts who understand the physiology. And so I think that miniaturization is a big deal. I think that whether it's 3D or 4D or some fusion of the image with other information will be there in the future. We've still got some challenges in terms of making those images as good as the images that we can get today in 2D. I can think in 2D. I can also think in 3D, but certainly my son and all his friends who play on computer games are thinking in 3D.
Right.
So we've got to make it that it's a 3D technology as a first line rather than as a reconstruction.
You've had a chance to certainly be around some of the premier individuals in our field, and you've become one of those, and you've also had a chance to be in some interesting locations. If you look back, what are some of your fond memories, or it's a hard thing to do, but tell me something that you remember about the field.
One of the funniest ones was we'll have to look it up, but I think it was 1989.
Okay.
It was the week before Memorial Day, and Ned Wayman came into the fellow's office and said, I've been invited to go to Dubrovnik next weekend. I can't make it. Would you go? And first I said, well, where's Dubrovnik? It's in Yugoslavia on the coast. I said, sure. I've got 3 talks to give. Here's some slides, and
go for it.
This was Kodachrome slides. And
I know.
I had to put some things together. Get there. It's a beautiful, medieval city, and with a lot of history. It was great, and all the greats were there. The Suud and Tajik, and Demaria, Dr. Emoto, and I'm jet lagged. I've never traveled overseas before. I mean, Echo opened up the world to me.
Yeah.
It's my turn to speak. Someone who I don't know introduces me, and now, Dr. Arthur Wayman will be presenting a talk on, the left ventricular remodeling. I give my talk, people are asking me questions, and here I am, probably 34, 35 years old, and everyone assumes that I'm Ned Wayman. And I'm trying to think, so do I play along? Do I play along with it? And it struck me is that these people were reading books, never saw the faces, particularly in Eastern Europe, never saw the faces of the people, but knew the names. And it was striking. And I made a lot of friends. In fact, that going home, I had to go through Zagreb. And the night that I had the layover in Zagreb was the night that Croatia seceded from the Yugoslav Republic.
Yeah.
And so there was marching in the streets. The airport was closed. I wasn't sure I was ever going to get out of the country. And so it was I got to see history in the making. It was sort of when the Berlin Wall was falling, and that was, Echo not only introduced me to a lot of great colleagues in science and in medicine, but I really got to see the world through, and will continue to see the world through echocardiography. And that's really been a great part of my life in Echo.